Dr. Kapur.
Sure, just give me a minute, please.
Okay.
I think in AMR, the biggest challenge is of prioritization. And the more we are expanding now from tripartite, we have gone to quadripartite. So I think it would be nice if we all could brainstorm through each of the points, and we are able to prioritize, 3 to 4 points. So all of us have amazing experience, and we all can share our input. So I can request first, we can go point by point. So first point, who would like to take a lead to discuss so that we are very clear what is it exactly that we are expecting under these and what is our input. So I request you all, then maybe I can summarize, or also I can give my inputs. So the first point is mandatory countrywide surveillance at all levels of healthcare, animal farm, etc., for local and regional reporting from different centers. So maybe here I would like to share what's happening in India currently. So in India, now for G20 also, one of the focus is integrated AMR surveillance. And we all will agree that primarily all the surveillance has been happening in the human health sector, whether it is the ICMR network or NCDC network or the state AMR surveillance networks, which we are now building under the program that in NCDC is coordinating. To bring in private sector also, but there is not much happening in the veterinary sector. There was a network called INFAR, which was initiated, but I think somewhere they had a lot of funding issues. So we are hoping that in the next year we will be able to find a way to fund them through one of the international agency, or let's see. That's already there in discussion. So that's what is happening currently at the national level. So I request all the other experts on this group to please share your inputs on the first point.
Maybe I could just begin. Given what we have seen as part of pharmaceutical company and our interactions with hospitals and physicians, I think while surveillance has picked up quite a lot in the hospital sector. And I think, Dr. Kapur, you did mention about the ICMR network, which has been bringing out periodic reports, the NCDC network. One of the areas perhaps to focus on where a lot of ID physicians tell me, and when I meet them, that a bigger problem probably is in the community rather than just the hospitals. So when one of the points really mentioned is all levels of healthcare. So at the community level, which may be the primary or the secondary care level, or at the 50-bed nursing home level, if I can say very simply, that may be an important area to look at from a surveillance point of view. So that's one thing I would consider. And of course, at that level, since the labs that are often involved are not really the leading labs, it could be local labs which are NABL accredited, perhaps forging some kind of partnerships with labs who are regionally strong. And I think it's mentioned also, Swati, in your points, to carry out community-based surveillance. I think the recent couple of papers in the Lancet, we've got a good data coming out from ICMR about the proportion of resistant organisms in hospitals. But I think at the community level is perhaps a gap that we could try and address. I can just add a second point. Recently we were doing some work on ophthalmic antibiotics, and we realized that while there is a fair bit of surveillance happening in the intensive care unit, but specifically, let's say, infections related to the skin or infections related to the eyes, or from these sites, which probably constituted a small proportion of the total infectious burden, we couldn't really find anybody doing a regular surveillance of, let's say, conjunctivitis or keratitis. Especially conjunctivitis, we had absolutely no data. We spoke to about 5 different hospitals, the leading hospitals in India, LV Prasad, a few others. There's no real surveillance happening there. So maybe we could think of, I don't know if that's a priority, but this is another gap that we just identified. I'll just stop here. Thanks.
Thank you. Anything from the others? Yeah, Padmini?
Hi, Lata.
Hi.
It's nice to see you. Yeah. So maybe I'll also come in. I think I agree that in terms of surveillance that's happening at facilities, healthcare facilities. There's a need to make sure that the data are not only coming from large tertiary care centers. So, which gives certainly a biased picture of what the antimicrobial resistance situation is, or might give that. On the other hand, we just don't know. And if we look at district level facilities or secondary facilities, and I don't know, maybe Lata, you can say how how those may already be part of the state level surveillance, since I've not been engaged in some time. But I think that getting data from these levels of facilities actually becomes quite important to get a fuller picture of what's happening. The two other things I'll say in terms, Lata, you're very correct in that the scope of what is possible and what the problems are is enormous. And so the real and so everything could be a problem. And so the challenge is really prioritizing where you are able to then generate data that are usable and will be used for public health decisions and are addressing problems that are associated with significant morbidity and mortality. And so I think that's also sort of within surveillance. How do you start to prioritize? WHO has come out with their list of bacterial pathogens. There's also syndromes and clinical patient populations where you may be more concerned, whether it's newborn sepsis, where we know that there's a huge problem, there's high mortality associated, or with other interventions or other types of infections where you can have an intervention to try to reduce the burden of mortality and the burden of resistance. So I would just bring that up in terms of when thinking of any surveillance. I think the first question is, why are we doing this surveillance and how are these data going to be used? And in order to prioritize, then would you actually look at where are you most concerned about high levels of resistance that you are unable to treat, or where do you have the biggest data gaps where you don't know if we have a problem and we need to better understand it? Or are you driven, where mortality is greatest and there's an opportunity and a need to try to set targets? So I think those factors should be, should be incorporated into the decision making, because countrywide surveillance in a country as large, the scope as India's is a huge challenge. So figuring out where it's possible to generate the quality data, I think, will be a key question. And sorry if I can just add, and I think Lata, you and I worked on this quite a bit, and I know you've worked on it a lot, and Jaideep also raised this, is where can you actually connect with appropriate quality labs? Which is a huge issue, right? Because it's not just collecting clinical specimens, which in and of itself can be a challenge, but you also need quality microbiology. And so when we talk about doing it at all levels of healthcare, where can you actually link up? And this kind of comes, it relates a little bit to some of this hub and spoke that's listed in point number 4, but and that might be bigger than just clinical facilities. You may be thinking beyond human health, but even within human health, in order to get these data, you need to figure out, how are you going to link specimens and how often are you going to do that? So there becomes a lot of practicalities of that, but at least mapping out where the labs can support this is an important first step to figure out where you're able to move forward.
Thank you. Anything from you?
Yeah, if I could just add a little more point. Absolutely agree with what Dr. Lata said and Dr. Padmini's points. I just think of it from a public health perspective, where a lot of data is being generated but not really captured. Maybe have some mechanism of reporting in a standardized format, because states eventually need to report to a central facility. Something like a COVID SRFID form that ICMR gives, and it needs to be reported back to it. So execution of simple tools like that, and also have some sort of uniformity in terms of how this data is being reported, so that it it's easier eventually at the receiver's end to make sense out of the data that is coming in. Yeah.
So let me share my experience with you over the last 5 years working in the national program, and I think all of these issues I would like to share with you the current challenges that India has when we want to tackle each one of them. So first of all, I think what Dr. Jaideep said is about the data being skewed. It is basically coming from ICU and it is coming from IPD patients. IPD patients are primarily those patients who are already severe, they're sick for a long time. So certainly we have data which is skewed, and NCDC's network is actually building capacity in medical colleges and states, and many of them were district hospitals previously. So our data ideally should be more close to the community. But let me share with you, because most of the data is coming from IPD and ICU, it is also skewed towards a higher side, that is showing more resistance. Because you will agree that not many doctors, unless it's in the private sector. Private sector, every patient who has fever will be exposed to a blood culture. But in the government sector, many people don't write blood cultures for people who come with fever. And even they may write a Vidal after 5 days, but they will not write a blood culture, or they may have already started the antibiotic, so nothing comes in the blood culture. So that's one reason why we have we see more resistance. And absolutely I agree, that is not a true representation of the data which India may have. And the second point regarding lab access, let me share with you that I worked in IDSP, that is Integrated Disease Surveillance Program, for 9 years, and there we tried to establish microbiology labs in district hospitals, and we realized that sample referrals were very limited. So it is not just about the lab infrastructure, and we realized large number of samples go to the private sector. So I do not agree that lab access is not there in the secondary care. It may be in the private sector. So many of the doctors send the samples to the private sector. And government also had started this free diagnostic scheme where the private labs pitch in. But I don't know how much private lab data fills in the gap in the in the public health system. So that is what was my concern when they started. Because they realized when they were funding, government was funding labs, there were no sample referrals. So they decided to have free diagnostic scheme where the private sector labs, who already have a lab, could be given first test funds and they could be utilized. But the challenge here is of whether that data flows in the public health system. So regarding the third point about, and I feel there is a lot of data in labs like LALS, and I feel if I fall sick, I have fever, I will go and give my blood culture to LALS lab. And you will agree that today, most of the private sector, the single units, are actually utilizing lab a lot. They are not doing syndromic management so much as it used to be many years back, because they have access to the private labs. So, and private labs are all over. You can go to towns in the country, you will find LALS lab branches. So maybe that's one place where we could explore. I think Dr. ICMR has tried, but I think they are not able to share, even the locality, so there are a lot of challenges there, but we could, discuss this and find out, because that's already data there and they're all accredited labs. And the third thing regarding, I think Priyanka's point about, having a centralized system for data collection, I think I here would like to support Padmini's point on quality of data. So in the national network that we made at NCDC, the report is available on our website. So we have a sentinel surveillance system, because we have taken few sites with whom we work very hard to help them establish quality. So when we began, the challenge was that they were putting colistin discs, and large number of resistance was being seen to colistin. They were not even using the CLSI guidelines. So now all our sites have switched from to the latest CLSI guidelines, thanks to the support we are getting. And now a lot of trainings are going on quality, and we also get these trains every quarter here to confirm them. And especially some alerts like colistin resistance, 100% strains they have to send to us for confirmation. So if we really want quality data, really AMR data collection is a very big challenge. If the QC of discs is not happening, the resistance that we will see will be very higher. very high. And I think that is one reason that, we cannot collect, like ministry keeps forcing us that you create a central portal, where everybody can feed in data. But our challenge will be that how do we know which ones are actually, doing quality work? And already we have gone through that struggle for 4 years and building quality in many of these state medical colleges. So that is a challenge. And that's why, like IHIP, like cholera is there, you have the data. AMR will be a little challenging if we create, but there is a talk in the ministry also of creating a centralized portal. At least the labs which are accredited, all over the country, their data, we could ask anybody to put in, but we could take that data to contribute to the national report, AMR surveillance report, and gradually we can push for. So I feel instead of increasing more labs, district hospital already has. We have made a lot of effort to build labs in the district hospital. Now there is another initiative funded by the World Bank called the Integrated, Public Health Labs, IPHL, where also we have informed that you should try to bring in AMR. But again, the problem is sample referrals. Doctors are happy sending samples to the private sector. Somewhere we need to work on how we can get the data from the private sector into the system. That we will have to see. I think that would be the lowest hanging fruit, easy to get, and the LALs and all have good quality labs. And so I feel that there's a lot which needs to be done. But on all the points that we have discussed, we could make some action points which are, short term. Like we can see how we can get the data from the private sector, and I still feel there's one gap which is there in the public health. As a laboratorian, I can say there's a one gap that I feel, and I discuss at many forums with the public health people in India, that in India, the primary, secondary, the tertiary care doesn't happen like that. A person does not first necessarily go to the primary care institution, then to the secondary, and then to tertiary. If you look at the state medical colleges which have come up, which have actually the district hospitals which have been converted to these medical colleges, the patients directly walk in there. So the large population in the OPD is also for primary care coming there. So we can't say, if they can start sample referrals properly, they can start doing case-based, and they are given clear definition who are the patients that you have to expose, to cultures. I think even from these hospitals, we will be able to get secondary care data, the community data. So that is my submission. Over to all of you for any more discussion on this point. Otherwise, we can move to the next one.
Can I come in quickly? No, thank you all. I just wanted to come in. I think this was a very good, perspectives from different stakeholders on the larger surveillance aspect. I just wanted to possibly request if we can now say what would we would like to do, in what we can do, something that is feasible in a manner that conventional stakeholders possibly they will take time to do, and something like a really nimble platform like IAIH could actually do in a very smart way. Let me give an example. I think we heard Dr. Lata say that, private hospital surveillance, whether we could actually come up couple of our hospitals which are already on the advisory council here, Narayana Health from Bangalore, a couple of others, if they could come in and participate in a 6 months, 3 months trial to do different kind of surveillance, whether we could possibly take similar thing, and I jump on to possibly a little bit fourth point, or which is there, 4B in a way, which is also there, which comes part of it. Or another, if I add to this, is another very exciting work that is happening because of COVID across, and which is going to be on AMR, which will COVID surveillance also happen significantly in many cities based on sewage. I think we know that, and they have done a very good job of it. Pune cluster, Hyderabad, Bangalore have done very, very, very good job of that. And we continue to do it in Bangalore, to be honest, still working with the municipal corporation, whether we should do AMR surveillance, because they have the model ready and they are already going to plan on AMR surveillance for that. whether we should onboard that as a point to do AMR surveillance through sewage sources which are already given to us. So I was just trying to say, can we now zoom in a bit and say what could be something we would like to do for next 6 to 12 months in a short period, and say that this kind of model, or if this done and the outcome of this can be represented, scaled up later on for the deployment at the national level, in which we can bring in, sorry for a longer monologue, in which we can bring in best practices, the best components of it, and ensure that those are built in and driven by somebody who is expert, but coordinated at IAIH under the guidance of this SIG. So I'll hand it back to you for your thoughts on that. Jaideep?
So, Taslim, so I have one other submission to make.
Yeah.
Normally, when we talk of surveillance, we usually talk about microorganisms, the resistance pattern, genomics, etc., etc. But I think one important thing which we know drives resistance is actually the consumption of antibiotics. So if we are simultaneously able to bring in the consumption of antibiotics, either at a state level or at a regional level, through people like IQVIA, right? And I could put you onto the team at IQVIA. If they are able to share with us country-wide consumption of antibiotics, with the way they collect data, of course, there are its own limitations and errors, but at least there is some data on gathering consumption of antibiotics. And Taslim, you may decide later that at the IIH or any such place, is there any correlation between consumptions of different classes of antibiotics and the kind of resistance you're seeing? So maybe that's an important thing to bring in surveillance. And I'm not going into whether the consumption is appropriate or inappropriate. It's just the data that's important.
That's an interesting input. That's I see the point. It is not stewardship. We are talking about the pattern generation based on it.
No, we are not about stewardship. We're not about appropriate use. So many countries are tracking consumption of antibiotics on a per capita basis or a per 1,000 population, whatever. Right? So absolutely nothing to read into the data, but just the data. Here's the pattern of antibiotics. Here's what's happening to, let's say, beta-lactams. Here's what's happening to carbapenems. Here's what's happening to aminoglycosides. If you're able to simply track that, just have the data without correlating anything at the moment. But that may be something we can do it without great difficulty in the next 6 to 12 months.
Very good point. I'll let others also comment on this and the previous points. Thanks, Ajay.
If I could come in and specifically on the previous point, and strongly echoing with Dr. Lata's point on, private sector being a low-hanging fruit, that is absolutely, has been proven to be true in a lot of cases. And if I look at our experience with TB case notification in the informal private sector, I think there needs to be some mechanism of nudging them. It could be an incentive, or it could be an incentive to the end user. Say, if they go to a private lab and they can give them some sort of an access to free diagnostic, which is mediated. The cost eventually is mediated by the government or by a development sector organization. That brings in more client base for them, but that also brings in more data and quality data from labs that are of the level of, say, Dr. Lal or so. So, how do we find a mechanism wherein we can nudge them to report, even if, to not the best of the best at the hospital level? And by best of the best, I don't mean in terms of quality, but in terms of the scale that they operate on.
So I would like to add a point here. I'm sorry I missed a little bit of discussion. But to the point that Mr. Taslim, Dr. Taslim has said, I want to share that I want to ask you one thing. This is what I feel is really helping us lose our prioritization in a country like India. The SARS-CoV-2 was a new virus. Looking for it in the sewage is fine. We never did that for influenza. We also have drift and shift happening in the influenza viruses. So in the AMR, I wonder why we will not find all the genes that we are looking for in the environment. They will all be there. Everything will be there. But I want to ask a simple question. What is the solution? See, I have been pushing now to understand, in India, we should keep consumption and AMR surveillance, antibiotic consumption in humans as the top priority. because what is happening in the pharma industry was happening many years back also, but that has not been the cause of AMR in our country. In our country, AMR has happened because we have been eating a lot of antibiotics. We should never lose that priority in our containment efforts. Yes, in the research point of view, I think environment should find, like we recently had a meeting with the Ministry of Environment who refuses to come on board, because they say that we have a lot on our platter, and they say that let's see in the hospital sewage, you do find residues. What is the solution? What will you do? Do you have mechanisms to remove the residues? And I think that's the point. If it's a problem, as researchers, we need to find a solution for them. Then they would take it as a problem for which they can do something. Same way, AMR in the environment, I feel, why is it that we will not find? AMR is a natural phenomena, which has been, even if you go to niches where human beings haven't been there, you will find AMR. So I feel what is more important if we are looking at AMR in the environment is more than AMR surveillance. It is important to understand that how is it happening? I mean, I feel it will still happen, but is it reaching humans? I think if we can understand the pathways, I mean, this is just a revolutionary thought that I have been attending many meetings and I've been thinking, because I still see in India, there is no focus on reducing the consumption of antibiotics among humans. And I can assure you that it is the one important driver in India. So from the research point of view, yes, environment focus is important. And pharmaceutical companies also didn't come on board. I distinctly remember I was a part of that meeting, and they specifically said that what about sewage in the hospitals? You have a lot of antibiotics which are either thrown, or even patients in their stool samples. We know much of the antibiotic is not used by the human body. It gets excreted as such. So I think we can work on more on antibiotic residues in the environment, and how much of it, what should be the standards, how much of it is leading to AMR. That could be the research focus. And then what can we do? So like somebody said that antibiotic has a shelf life. Why in the environment the residues don't have a shelf life? I'm sure they have. So I think there are a lot of research questions which people who are going to get affected by our standards in the environment or things like that. They asked me that why should we invest in looking for AMR in the environment? It will be there. It will always be there. Either it will come from the sewage or it will come from the farms, whatever. So I think I'm sorry if you, I hope you understand what I'm trying to say. And that is why prioritization is very important. But I think in environment, we should try to focus on finding what are the pathways by this AMR is reaching the humans. Is it actually reaching the human gut itself is having so much antibiotic? That could be the first reason that we develop. I still am, as a clinical microbiologist, I still don't believe that, with a population like ours who's eating so much antibiotic themselves, our own flora, gets exposed to these antibiotics and we develop resistance rather than we getting it from the environment. So again, here I would request that it's very important to keep some things from the research point of view for research. And that's what I've been promoting everywhere, that these are research questions which nobody in the research, is actually answering. The transmission pathways, if there is AMR, what level of residues are making it happen? And what is it that we can do to remove that residue, whether it's, keeping it long term and, before throwing it. It's not so easy to get rid of residue, especially in the hospital sewage. And if it is leading to AMR, is it really reaching humans? Is it the same AMR which is reaching humans? We all know Omicron, at the same time we found mutants, the new variant in many countries at the same time. It was not necessarily that it got transmitted from one country to the other. So same, I feel AMR also, spontaneous mutations are happening. And we cannot necessarily say that the transmission is this way or that way. So there's a lot of brainstorming which researchers need to do before we can convince people, whether it's in the pollution board, whether it is in the Ministry of Environment. And I think we need to come up with solutions before we start prioritizing the environment. So I'm sorry, Dr. Tasleem,
No, Dr. Radha, not at all. It's not. These are thoughts on the table, and I think unless we have perspectives from each other, we can't build it. So this is what my job is to nudge for the feasibility component. Since all of us are working in it, I think we have perspectives which are, and that's why we are here, all of us, to build it together. So I perfectly respect those views. I just wanted to come and say that. So what is that we still have 40 odd minutes. What is, I think, and we haven't heard from a couple of other colleagues, but what is that are we looking at possible surveillance from a hospital based surveillance? If you're looking at hospital based surveillance, are we looking at inward surveillance? Are we looking at the these whatever the sewage surveillance, the release surveillance? What is that we should build that will which kind of data and possible intervention is not available in India, and we can show it back? So what exactly that would be? If we can come one step by each, come to that, that'll be lovely, according to me.
So one thing that I would like to highlight, which is the biggest gap in India right now, is there is no data on antibiotic consumption in the human health. We keep saying animal health is eating a lot of, they are using a lot of antibiotics, but believe me, it is the human health which is still using the highest amount of antibiotic in India. And I think that kind of a surveillance needs to build in. And I don't see it being prioritized by anybody. Until we start showing those figures, the clinicians refuse to understand and accept that the problem is primarily in the human health sector when it comes to India. So that's one. And the second is quality AMR data, which Padmini had said, whether we tell the PSA to enforce accreditation, PSA office, that government has to enforce accreditation of all labs. Why should government labs not be accredited? Why should they be not having the updated guidelines when it comes to, analyzing their AST results? These are the two things, so that all the data then can be taken at the national level, whichever lab. If everybody is like you see in Europe, all the labs are accredited, and they do not have to think twice before accepting their AMR surveillance data the way it is. So those are the 2 points which I have. Maybe others can please add.
So maybe I can come in first to the point that Lata made earlier, and others also did on the private sector. I agree, actually, that's probably a high, it seems like there's a consensus that that's a high priority and a potentially achievable one in terms of, at least at a pilot basis. I don't think that it can be done nationally right away. That at least at a pilot basis in either a particular geography or with a particular set of private labs or private health groups, that there's a potential of actually involving that private sector and developing an appropriate mechanism to include those data. And I agree completely. In fact, I was going to bring up the same example of incentivizing TB notification, which was started initially in Mumbai and Bihar, and then now has taken off. And you will have to figure out some of these incentive structures to support bringing in these data and making sure that those data also achieve the same quality levels that you're looking for from the public sector should be matched in the private sector as well. So, if you take it you're looking at a timeline of 12 months or something like that, or even 24 months, to be able to, circumscribe what it is that's achievable to actually make a model of bringing in private data and incorporating the private sector. I think that's one that's quite doable. On the issue of sewage surveillance, I think there's sort of two aspects to it. I think one is looking at residues of antimicrobials themselves, and the second is actually using sewage surveillance to look for markers of antimicrobial resistance, so antimicrobial resistance genes. The latter, I think, there's been some interesting papers that have come out just in the last month, and I'm happy to forward one that just came out, a global one on urban sewage surveillance for antimicrobial resistance genes in Nature Microbiology, I think. And I think what it suggests is in a situation where we'll never be able to capture at a clinical health facility from human health specimens the full picture, because we're not going to be able to actually do surveillance at that depth and at that breadth. And that the potential of, can you actually surveil in urban sewage, for example, that can be representative of what the AMR situation is in that locality. And what they did see when they looked at this global analysis is, at least regionally, and there are differences, and that can, if you break it down as a global region, perhaps within India, it could be something that could be looked at within regions in India or even within specific areas to see, are there markers of resistance that we can get a picture of, that can be a picture more broadly of an urban area rather than only looking at a healthcare facility, which otherwise would be the natural way to get clinical specimens. I don't think, that's, I think, again, something that would, I think Lata brings up a good point in that, these are new and interesting ideas and potential is there. So it needs to be something that is relevant to government programs, or, something that can either be taken up as a program or a pilot research to say, is it feasible to do? So that I just wanted to raise that because there have been some interesting data recently on sewage surveillance for antimicrobial resistance genes and markers, and where are we where are we seeing that evolution? Are we seeing greater levels of certain markers? Is it different in some areas versus others that might actually reflect more the community than just looking at clinical specimens from hospital-based surveillance? And then I will defer to others on antibiotic consumption surveillance. I think it's certainly a worthwhile endeavor. I haven't been focusing on it as much lately, so I'll defer to the others on that.
So maybe I'll just add that clearly that when I said antibiotic consumption surveillance, I mean both as far as human is concerned as well as in the veterinary or the livestock sector is concerned. Because Padmini, what you mentioned about presence in the sewage could come from either of the two sectors, right? So it could be representative of not just what is in human health, but also in the animal health. So that will give a reasonable reflection, I think, and I'll be happy to see the Nature Microbiology paper, what it reflects. I think the point you made about getting local kind of resistance based on this, it's an interesting idea to look at rather than just national. But I would certainly go for antibiotic consumption surveillance, both in the human and the animal sector. As I said, the human sector, it may be possible to get the data and just track the data on an annual basis. And importantly, looking at seasonal trends. For example, when you see respiratory illnesses, you see a big jump in some of the respiratory antibiotics. In the old days, when we would have the summer months or the rainy or the monsoon months, we would see a GI antibiotic pump coming up. So it'll just be useful. I think what we do with the data is part two, but I'm sure we can figure that out. But at least right now, it's important just to collect data.
Can I ask, Lata, what is happening on animal AMR surveillance? And if you can share sort of what you might be aware of that's happening on the animal health side. I am aware of somebody working within the PSA's office more on animal health and animal husbandry who I happened to speak with who has also said that there is scope to actually map out some of these data, but I don't know if that's something that the Ministry of Animal Health or Husbandry has already started in a systematic way.
So they have done a small study on consumption that I know, because one of our network labs from Aurangabad helped them, implement that and find some data, which I think they've also submitted to OIE, but the WA. So I think the problem is of sustained funding. So I don't know. I'm really looking forward. We have Fleming Fund 2 coming, and sadly, in the first phase, we only supported the human health labs. But I'm hoping that in the phase 2, we are able to support the animal health lab, especially this network, because you will agree that there is a problem. The problem in the animal health is that there are only veterinary institutions which seem to have some capacity to do AMR surveillance. And that's why if you see AMR, the INFAR is primarily of fisheries and animal veterinary institutions. There are no labs like, we have in the private sector, or that's not there. And so they have limited laboratories which can be involved. And I think the one thing that I have noticed very carefully, because we also did one integrated One Health surveillance under the Indo-Netherlands collaboration, where we funded them through NHM. We realized that the quality, that they need a lot of training. So this was a lab which had full confidence that they were doing very well. But when we got their strains to confirm here, they had some QC issues. We realized that a large number of colistin resistance that they had reported were not actually colistin resistant. And so we confirmed them here. We have a national reference lab here for our, for glass, which also we confirm various strains which we get in our network. So, so they need a lot of hand holding, and we are hoping that we are able to fund them for at least next couple of years and build their capacity. But otherwise, I don't see what more can the Ministry of Animal Husbandry or the Department of Animal Husbandry do. I don't see their labs within districts having the capacity. Even state level labs do not have much capacity. And till there is a desire from themselves, to do that, even if they get some funding for an year or two, that's not sustainable till the ministry itself drives, that they need labs. So I feel we need to first build evidence. Now we have enough evidence in the human health sector. It is easy for us to promote establishing labs or getting them accredited in all state medical colleges. But I think in the animal health sector, we need a good infar network to do well for at least next 2 to 3 years, build in evidence. And maybe, then, so I have some friends who work in the animal sector, but because their exposures to antibiotics are very low, especially the pets and all, whenever they get. So one is, of course, the farms, which is using a lot of antibiotics as per reports. But I still have, whatever discussions I have had, I feel still human health is using much more in India. So if we can have data on consumption and a good infar network, which gives an evidence on what is the state of AMR through the veterinary institutions, through quality, labs which are quality assured, which can have a regular EQUAS. We could support in the EQUAS. We're trying to establish capacity at NCDC to even provide some EQUAS. As of now, we're getting some support and we're getting it through CMC only. But I think there's a lot of things which needs to be done in the animal health sector. Not much is happening there. There is no evidence, no report of infar yet, which started almost 4 years back.
So when you have this point number 4 that's been raised in this slide on integration of surveillance data collection, I'm assuming this is integration not only from different levels of healthcare, but of different types of data, both human and animal. And I wonder if Taslim, if our job or our job today is to come up with ideas that could be considered in a near-term framework. And I don't know if this has already been done, so Lata, you can correct me, but when you think of integration of different types of data, is that something that could potentially be focused in a geographic area, even in a district or state might be ambitious, but in a few districts within a state to say across human and animal sectors, we'll try to get these data. Both potentially, focusing on consumption, or if there are specific pathogens for which the animal sector is also interested in doing surveillance for resistance to human antibiotics that cross over to the human health side. Is that something that is worth considering? I'm just raising it, not knowing what would be of value and interest and feasible, but as an thought.
So that is what we did under the integrated AMR surveillance, that we got them for the AMR surveillance. We got both human health lab as well as the veterinary institute lab to report in the HUNET, and both the HUNET files came to us, and we then created, analyzed the data and created the comparatives, like how are they comparing, and with that small study that we did, we realized that the AMR is more to the antibiotics that are being used in that sector. This is a small little study, so I don't want to harp on the conclusion, but that is what gave us. Now we are planning to fund some more projects, which help us. 23-24, we plan to fund some more small projects where we can do integrated AMR surveillance. But I think that's it. We need to. I'm not clear about this hub and spoke model. If somebody can clarify, but this is what we have done at NCDC. That we took both the HUNET data sets and then we analyzed the data and we saw how does it compare with each other, and we shared it back with the sites.
So if I may come in, I think the idea is that this is just a food for thought that was built in a manner that could there be a very small structure which would allow a hub and spoke model where there is a central entity, let's say a citywide or something, which integrates two or three eh, public entities and two or three private entities, and build a participation and coordinate that for surveillance data collection. Interestingly enough, BBMP here has already have something planned. So could this be, idea was that could this be a citywide or even a, if I once say, small, a ward-wide effort, this actually can be also effective. But that was a thought that can we have a hub and spoke model? This was just a food for thought. Jaideep, sorry.
So maybe Dasim, I can just relate an experience that we've had over the years, not in the field of anti-infectives, but in the field of pulmonary health, where we've been very actively involved in a lot of epidemiology and data collection. So one of the centers, which was a private trust of Cipla, but is now no longer. I don't know if you're familiar with the Chest Research Foundation, which was there for about 20 odd years. And now it has taken on a new avatar, which is completely independent. So they established what is called as the Respiratory Research Network, or RRN, across India. And for 2 or 3 diseases, they were able to collect remarkable data across the country and publish it in many leading journals, actually giving an impetus to the government about the burden of respiratory health in India. So one of the studies I was personally involved in many years ago is actually a collection of data of 200,000 patients from India visiting a general practitioner. And what we did is we used the sales team reach in all parts of India where Cipla had. We have over 10,000 salespeople on the ground. So they actually went and sat for about 8 hours in a general practitioner's clinic, which was randomly picked up. And they, in one sheet per patient, they collected data, which was then sent centrally. So at that time, it was done paper-based. But today, they have a system where you can have a central system through a registry where data collection is done. So it's not a hub and spoke model, but there could be opportunities where we could leverage that kind of expertise that has been built up. In fact, the gentleman from this center went to Johns Hopkins and got trained on how to build actually networks across the country. So they spent about 6 weeks there to get trained and come back. And they have set it up again, and we're just working with them for one more project, which is currently being up the aspergillosis registry in asthma patients. So that's actually now ongoing. It's a very difficult disease to identify and treat, but there is expertise like this available in our country. And while it may not be specifically to an infectious disease, but if there is a general expertise of registry and data collection, maybe there is an opportunity to use them, and they could sort of reach out and collect data from different hospitals or different labs rather than one lab itself in any city. It could be independent of everybody, so people don't have the impression that so-and-so hospital is getting my data or so-and-so lab is getting my data. Could there be a way we do it independent?
So from the human health side, yes, you'll be able to get that kind of a data, but I think the challenge will be from the animal health side. We'll have to figure out. I think most important is to strengthen that one network that they've been able to establish. If we can do that, then we can see, how we can form local linkages or, get the data to one forum and then one platform, and then see how, an institution in a particular locality and the data coming from the medical college from the same locality, which is both quality data, how they compare. So that could be but I think we need to do a lot of effort in the animal health side.
My only submission was if you have an independent center, which is independent of all hospitals and laboratories, maybe people will be more open to sharing data, knowing that it's a neutral party and not a particular hospital or an institution.
Yeah, that is true. So I think that's how ICMR is, that's how we are. So we do get data from centers and they're very happy sharing. Of course, we do give them some incentive in terms of some manpower because but I feel in the long run, surveillance will be required even to monitor the efforts that we do for containment. So I think, and also ultimately through surveillance, we should promote evidence-based use of antimicrobials, because even if we get the expensive new ones in India, this is my scare that everybody wants to bring in access to the newer antibiotics in India. I'm very worried that they will lose them equally fast. So that's what we have seen in the single units across, especially in some of the towns. The new antibiotics which are in the actually the reserve or the observe group get, especially in the reserve group, gets used very quickly. So I feel that if we also, along with surveillance, want to promote evidence-based use of antibiotics, it should become more like, in the West, it is like a culture. Even if the antibiotic is available, there are very few people I see who awareness is raised to the point that they will not use an antibiotic. They will themselves, even patients who are well educated, they will say, first I will give my culture. Even if the doctor has written an antibiotic, they'll go and give a culture in the private lab. So that kind of an awareness, and ultimately AMR surveillance the base should be to promote evidence-based use of antimicrobials. And regarding Padmini's point on see, with surveillance, in India, my worry is, yes, it could be a research where we find in a locality where there is effluent from a pharmaceutical industry and we are finding a lot of AMR, we could correlate the two. And we could, put more pressure on the pharmaceuticals, or it could be an hospital sewage site, maybe that could be the reason of AMR. But my worry is that the way the media picks up these articles, research is no longer staying only in journals. And my worry is if it comes as a headline that we have cholesterol resistance in the sewage of the city, for all all clinicians will start using the latest antibiotic on patients. So we have to think about the whole thing holistically. And we can certainly do that kind of a research. Yes, it is going to be very useful, but it should be used specifically to put impact on that particular sector. And that is to put maybe, work towards finding solutions to reduce residues in the sewage of hospitals, or because during COVID, I saw so much of research going into clinical minds, and which really distracted how we treated our patients. And I'm unable to forget how, science misled on a lot of things, including the use of ivermectin. So I'm very worried. And some research should stay in research and those kind of journals. It should not come to the common public, because even the clinician will, let me tell you, I meet a lot of clinicians, not many understands that AMR is a serious issue. And that is what worries me even more, because if they don't understand, then I don't know how we are going to, contain AMR, especially in India, where we have so much antimicrobials available. So I agree with your point, Padmini, but we need to do it in, like that, in a hidden way, so that it doesn't come out in the public and scare our physicians and they start using the latest antibiotics even more.
So maybe one suggestion, Dr. Kapoor, I may offer is what you rightly pointed out, that perhaps in the environment around a pharmaceutical company which is manufacturing antibiotics, or a large hospital, or sometimes, like I know in Bombay, there's a cluster of hospitals in a certain area. Could you think we could ask or request or encourage the company or the hospital themselves to do the surveillance for their own good? It's actually for their own good, right? It's a reflection of what they are doing. Because we do know that one of the big things in pharma today, and we are all part of it as companies, is environment sustainability, EHS as we call it, environment, health and sustainability. So it's a big part of most large pharmaceutical companies. So if we can ask them or encourage them or incentivize them to do on their own, maybe that's a step, it is one step ahead.
So for residues, yes. For AMR, maybe they may not agree, but residues, yes. I think if I remember again the discussion that happened when the standards were being discussed, they said the API industry was very clear that we are very strict. It's like gold for us. We don't let any API go waste in our. But the problem comes with the finished products. And the industry which is making the finished products, it is very challenging to help them come on board. They are the biggest defaulters. And again, the good pharma companies will agree, but the problem will be of this large chunk who are making the finished products. And So I don't know. I don't know. I feel we need to find two areas of research. I don't know how we can push it there. One, of course, surveillance to see what are the residues. I mean, what are the the genetic elements or markers of antimicrobial resistance in the environment, and also see what could be. It could be just a research question, as Padmini said, on what could be leading to so much AMR in a particular locality and not in the other. So that could be a research question. And regarding the pharma, I think uh, so. I absolutely agree with you. I don't know. I don't think in India we can tell them that you have these standards and you have to implement them, because they are not agreeing, because they still say that hospital sewage has much more antibiotic residues than us. So they could form their own standards. That is, the Ministry of Environment is still struggling. Last time I met them, they said that NGT is and saying that till you find lesser number, lesser level of standards, you please implement your stringent ones which you made initially. So I don't think there are any standards at the global level. Do we have any standards for residues in the at the global level in the in the
Uh,
pharma effluents?
So I can check. There was a AMR declaration that came with a bunch of companies who got together as an alliance. I think it was called AMR Industry Alliance, which formed it. I can dig that document out and maybe share that with the group.
Okay, because they had last I remember they had shared with the expert who was there from UNEP that if they can help, if she can help them find,
And
those.
it may be a phased way of approaching, because I know that what you rightly said, the medium and small companies may not be able to do it overnight, but there could be over a phase period, maybe getting people to sort of comply to this more and more.
But they had one more query, which is absolutely fine. They said, why only the pharma companies? Why not the hospital effluents?
I agree. So I think we should also start talking to the hospital associations as
No,
well.
but then what is the solution? The patients, I agree, you don't dump it in that, you find a way. But then they also say, I think we also need to study if a patient in the hospitals, what about the sewage? Does it have a lot of antibiotics? Because as we say that a lot of it goes as such, it gets excreted in the sewage. And I think we must find solution as to how we can actually degenerate or completely make it inactive, that antibiotic. So if we can find those solutions through research, it will be easy for us. See, if you see right now when you talk about biomedical waste, the CPCB has given a mechanism. What you do, you autoclave it, and then all the lab waste must be autoclaved, and then so there is a solution, and then you have standards. So I think if we do find standards for the hospital's sewage, it may not be just antibiotic dumping, but it may also be the patient who's having a lot of antibiotics. That sewage could also contribute to AMR residues. And then if you can find some way how we can inactivate that so as to it does not impact the emergence of these genetic elements or which can then go across to our pathogens and confer resistance. So I think we need to find solutions. That is very important. If we can do that, then I think create focusing on this problem will have some, because if right now we tell Ministry of Environment, then they say please give us a solution. CPCB is struggling for solution, what to do, what should be what should I tell the hospitals to do to get rid of this residue, even if I do find it.
So what would be, let's say, a couple of things that we could possibly build?
Yeah.
Yeah, Jaideep?
So, Tasim, I would definitely say that tracking antibiotic consumption, either we could do both human as well as veterinary consumption, if you're able to track through data which may not be 100% available, but at least gives you a trend, because you can't get 100% data, I'm sure, but a trend. There are a couple of databases by which most companies collect sales data, but I think either the government or anybody could approach them, or CCAM can directly approach them. Tasim, and I can give you a contact there. CCAM could directly approach them as an independent party that, one of the big things is AMR. Can you help by just tracking this data? We are not going to comment anything on that, just that. That could be one. I don't know from the livestock or veterinary use, is there a database, but I can check on that from our sources. That's the thing. And so number two, I would say, I think we should dig deeper into how to get into the secondary levels of healthcare. I think most of us quite agreed on that. That while most of the data, I mean, India looks terrible on the world map, because whenever I meet people, it is 85% Acinetobacter resistant to carbapenems, and you see emergence of colistin resistance has been identified as a priority pathogen in India. And, people just get terrified when they see that. So I think we have to put it in the right perspective. So I think going one level below the tertiary hospitals is, whether it is large lab or the regional labs, if you are able to identify 7 to 8 zones in the country, and I'm sure the government knows how to approach these zones, talk to regional, at least the accredited labs, and request them to share data on maybe 10 urine samples, 10 swabs from the throat, or 10 blood cultures, 10 respiratory cultures, just 50, 60 samples. We don't really need all the data. What would be reasonably representative of the kind of patient pool that they are getting, whether they come from the public or private sector, is secondary. If we are able to set these 2-3 things and maybe pilot it in 2 zones, let's say west and south or east and north, whichever way we can pilot it, where we have labs which can, which are happy to work with us. Maybe those would be 2 priorities, I would say, at the moment for this, because we're talking about preparedness as well, right? So I think getting the whole infrastructure prepared, I think changing their mindset is as important as them doing actually something.
Fair. Thank you.
Yeah, I think that's a very good idea. And I think we could even focus on an age group, the younger adults, because the younger adults will not have any comorbidities or, repeated hospitalizations. So we could have more community data, from these private labs.
Yeah, no, thanks for that. Padmini, do you think something like this could be attempted where we would have the understanding and that would help back at the national level to influence the way, how would be outcome of this would actually help us at the national level if we have those trends, whether it would build a policy towards higher consumption of something, or what would be your thought, Padmini? You are on a mute. You're on mute. Yeah.
Sorry. Yeah, I think that's probably a worthwhile discussion, just even at the outset, in terms of how these data would actually be used by national or even state level decision makers. And to start that discussion early is probably worthwhile, because I think it's important to say there's a plan to collect systematic data, because policymakers and others will always say first, well, I don't know, I cannot make a decision because there are no data there. And if you show that there is an actual plan, well, if you had these data in this systematic way, what would be the decisions you would make? And to map that out a bit, I think would be a worthwhile exercise, at the start of this sort of endeavor.
Fair point. Thank you. Priyanka, Dr. Priyanka?
I think these are valid points. I was just, maybe thinking aloud. There is so much data that is coming in and that would come in. How do we define a template for actionable data is something that, experts here would need to work on. And that can be replicated, not just at, say, one intervention state or, at the level of one facility, but it's easy to replicate. Another thing, I again come back to this point of the sewage surveillance and environmental surveillance. I've personally worked on this, so this is very close to my heart. I tested for the AMR genes in the water of Yamuna River that is flowing through Delhi, and there were some very, very interesting findings, including ESBLs and extended spectrum cefamycins on transmissible elements. So it's not just sewage. This water is being used. I mean, people take a bath in Yamuna River in Delhi, and this is used for irrigation and crops, and it's coming into our chain. Your point is very valid, Dr. Kapoor. This is research, and how this comes across to the public is very critical. But I think it should still be in what we are doing in the overall surveillance. And in fact, when I was at that time, there was a very big issue of heat of NDM1 and how that was named after New Delhi, and people very clearly defined that ESBLs are moving from India to the US and MRSA is coming from US to the Indian subcontinent. when we capture this data, not just the clinical demographic, but also some sort of a travel pattern, just for our going back later to tap into if there is some outbreak associated with travel and how that is shaping the AMR.
Yeah. So I then request Chair to now comment on this and see whether we can build at least top 2, 3, which we can at IAIH, Dr. Lada, we could possibly, a little bit make a deep dive and come back to the group on email on feasibility. But I think your comments will be valuable for us to build those last 2, 3 possibilities and come back to the group.
Yeah, so I think integrated AMR surveillance is very important. And I think as we have discussed, that should be one of our very important point that we should focus on, because we still don't have, we have a lot of data, one from the human health, but that is very skewed, we agree. And I think the point about, taking this kind of a data, which is representing more the community data, one of the most important utilization of this data will be to question the national data, current data, which is so skewed. So it could actually question that you have so much resistance, but actually at the community level, it is not. So that could be one thing. Second, so I'm just giving you the output of the integrated AMR surveillance, and an AMR surveillance even within human health, which is more, getting more data on community level. So that should be our focus. And also, I think Dr. Priyanka talked about ESBLs in the river, but recently there was an article on the phages on the river. So, how they are. So we environment is an area of research. I would still say in India, we should push it under research. Actually, if you see, even the research agencies are not doing enough for environment. If you build in clear evidence, then it wouldn't be pushed in the mainstream. So I would still say integrated AMR surveillance for India should be primarily in human health and animal health, and because and of course consumption should be another bullet. So one is AMR surveillance, one is antimicrobial consumption surveillance. And when it comes to AMR surveillance, yes, we should make all out efforts to get in some data from the secondary centers, from the secondary healthcare centers. Maybe it could be private labs, which are being accessed more by, directly by the patients in the community. And the actionable data, I feel this data. So these are the 2 pointers that I feel. Other than that, please feel free to add. But regarding actionable data, if you look at the ICMR report today, why do you think the clinicians in India would not use the latest antibiotics? It is driving the clinicians to use latest antibiotics. And if you tell them, please use access group antibiotics, they say, but your national report says that it is all resistant. Why should I use? So I think that data will become highly actionable if we have case-based surveillance data of large number of people who have infections, not just the ICU and the IPD based data. So I feel a lot of use will be there of this data. We will be able to promote more use of antibiotics in the access group. That would also be a good utilization of that data. This is what I feel. So these are the 2 points that I want to emphasize on in the surveillance, this SIG.
No, thank you, Dr. I think what we'll do is that at IIH we will, I think, put together some of these points, get some level of feasibility check, and come back to the group in a week or 10 days time on possibilities. And once we are confirmed, we can then on email only we will discuss the next steps, including your inputs on how this could be taken forward, the approach, the design, and so on. And also possibly, which is very important considering this entire platform is not core funded by in a way from any entity, how do we build resources to build such studies, and which can help the Office of PSA later at the national level. So we'll come back to you with those 2 points. I think we have a couple of minutes. Any last comments? Swati, do you have anything that you wanted to check before we kind of close at 11 in India?
No, I think you've summarized it well, Tasleem. I think we have the work cut out for us. We'll sieve through all the points that have been discussed today and put it in a form that we can draw focused inputs from all our SIG members. Dr. Gokte, it would be great if you could share the document that you were referring to, or the contact point. And Dr. Padmini, do share the nature paper that you were referring to. In the meantime, we will also be sharing this recording with Mr. Neeraj Jain, and Priyanka, do help us in getting his inputs so that we can incorporate that before we send out the communication to the group members.
Excellent.
Okay.
Thank you. Dr. Lata, with your permission, I think we will close on this for today's meeting. For your, if you may want to, possibly have last words for today's session.
Oh, I just want to thank everybody. It's always like AMR has become so much a part of me, being part of so many groups, and I'm really thankful to you for hearing me out, because sometimes my thoughts are really the other. They are very tangentially in a different direction. But we hope that we as a group can prioritize what really helps India, to contain AMR, and prioritizing it is the most important. Thank you. That's my last comment. Thank you.
Absolutely. Thank you all. Thank you all for joining in.
Thank you, everyone.
Bye-bye.
Thank you. Bye.
Hope to see you soon again. Bye-bye.